Good afternoon, everybody. I'm Katie. As Tally said, I'm the Director of Operations at HCS, which means that I oversee both our community programs, so our nutrition, transportation, home support, and foot clinic. And I also oversee a lot of our internal operations. So I oversee maybe our facilities, our IT teams, the things that make us go as an organization. And also our events team and our community relations. I like to have my fingers in a lot of pots. And you know what? It keeps the days interesting. And it helps me learn so much more about our organization. It helps me learn about what our communities really need. And so I'm hoping that today I teach you a few things, and maybe you can teach me a few things too. I'd love it if you'd ask questions throughout this presentation. If I gloss over something that you'd really like to know more about, raise your hand, stop me, say, hey, I'd like to know more about that. Tell me about this, or I have a question about XYZ. So, first, HCS is an organization with many programs, and I'm so glad that you're here with us today because we encourage people to know us before we need us. We have many ways to support our community, yes, for our seniors, but also people across the lifespan. And so I'm so glad that you're taking some time today to learn about the programs that we have, to learn how that we can support you, your colleagues, your families, your neighbors, and how we can be helpful in this community. There's lots of ways to get in touch with us. We're on Facebook, Instagram, and LinkedIn. We have a fabulous website led by this lovely lady over here. And this is our mainline phone number. You can reach us there 24 hours a day. In the evenings, you can leave us a message, or if you have a crisis, a nurse can pick up the line. And we also have an info box too. HCS has a really rich history. We started serving the community in 1907, actually right here in Peterborough. Our organization started as the Visiting Nurses of Peterborough back in 1907, and that was almost 120 years ago. Our first nurses walked or took a horse or a trolley to see their patients. And in the 1980s, multiple organizations that were doing similar things came together to become the organization that we know and love today as HCS. And HCS has looked pretty similar to what we've been doing and the programs and services that we have since about the 1980s. And while we look a little bit different today than we did in the 80s or even back in 1907, we're still serving our community 365 days a year. Many people hear our name, home health care, hospice, community services, and really assume that we're only serving older adults in the community. And that's not true. As you hear today, our services support pregnant people, they support children and teens and people throughout their lives, and yes, older adults as well. I'm going to take a minute to read our mission, our vision, and our values. I think this is something that I think is really important for you to know about how we exist in this space as a nonprofit, to help you understand how we think about our patients, our community, and how we as a nonprofit really try and support our community. So the HCS mission is to provide services which enable people to function throughout their life at their optimal level of health, well-being, and independence according to their personal beliefs and choices. The HCS vision is to be the leading regional provider for the continuum of care through home health, hospice, and community services. HCS values the spirit and talent of a diverse and inclusive workforce that can use evidence to support practice, employee competence, and meaningful work in our holistic approach to meet the health and wellness needs of individuals and families. We value the ability to change nimbly with the aid of technology and continuous improvement, which protects the rich relationships that lead to professional collaboration and donor confidence. And that really says all of these things together. when we as senior leaders at the organization are trying to make a decision about what the organization is doing, how we're going, we really hold our patients highest in regard. We think about how can we give the best quality of care to our patients and clients. And then we think about our staff, because our staff are the ones that are out in the community actually providing the care that we give. And then we think about our community at large. How can we as a nonprofit in this space be serving our community to the best of our ability, to the closest way that we can to our mission? The HCS service area covers 52 towns in southwestern New Hampshire. This is what I fondly refer to as our polka dot map. Since we have so many different services, this gives you a little snapshot of all of the services that we have available in each town. And you'll see it looks different from town to town. And part of that is funding. We are a nonprofit. We do have to be funded somehow. We have some funding that is really only in Cheshire County. But our clinical services, which I'm going to talk about in a minute, are available in all of our service area. So our home care and our hospice services are available in all of the 52 towns that we live in. And a show of hands, who lives right here in Peterborough? All right, so there's a lot of you. So who lives maybe in a town touching Peterborough? Close by? Yeah. Is there anybody from more over on the Keene side of things? Anybody make the drive out? All right. So I will touch on some of the services that we have in Cheshire County so that you can hear about some of the things we do there as well. Oh, one of the other things I should say is on this map you'll see 3 different stars. This is where our offices are. We have such a large territory that we have 3 different offices to allow our staff the most flexibility of where they can go for help, a break, or other kinds of support. We have an office right here on the Monadnock Community Hospital campus. Over in the Medical Arts Building, we have an office there that houses our foot clinic, that have Healthy Starts visit, and this is Nancy Onisor. She is our Peterborough office manager. You can see her there most weekdays, and she will be happy to greet you over in our office. We also have our main office in Keene, New Hampshire. This is a big, beautiful building on Marlborough Street, and this is where most of the daily functions of HCS take place. We have our executive offices there, our IT, our facilities folks. It's really the hub because it's also sort of central to our territory. We're very lucky to have this big, beautiful building, and we have a few tenants as well. It's more building than we need. So we've welcomed the Keene Senior Center into our building as well. So they're not affiliated with us, they're not one of our programs, but it is a really lovely collaborative partnership that we have, that we throw events together sometimes, we do friendly meals together. I'll talk more about those in a bit, and it's really lovely to have them in the building. They've brought a liveliness to our building that has been really wonderful. We're also lucky to have Dr. Miller, who's a geriatrician. She sees all of her patients in our offices as well. She has a couple of offices there. We also have an office up in Charlestown for our more northern territory. This is not a staffed office, but it is because it's a rural area up there, it's a great place for our staff to make a quick pit stop, eat their lunch, have a safe, quiet place where that they can go so they don't have to be in their cars all day long. Because as you can imagine, with this territory, our direct service providers, our nurses, our therapists are in their cars a lot, driving to everyone to see them and have their needs met. So let's talk a little bit more about our programs. So first up, let's talk about the VNA, or the Visiting Nurses Association. We often refer to this as home health. And so you'll hear me sort of go back and forth between saying home health or VNA. So the visiting nurses have 5 disciplines that are part of this program. There's skilled nursing, physical therapy, occupational therapy, medical social work, and home health aides. Now, what does a visiting nurse do? A visiting nurse is providing high-level clinical care right in your own home. They might be doing wound care, managing catheters or other medical equipment. They might be drawing blood for labs. A visiting nurse will come after maybe a hospital stay or a surgical discharge to ensure that your recovery is on track. They can prevent readmission to the hospital by catching complications early. Visiting nurses are often the care coordinators of the team as well. They evaluate the need for other services like physical therapy, occupational therapy, social work. And they really lead and guide the patient's recovery and manage the care to connect people with all of these services, sometimes that we provide, sometimes that other organizations provide as well. And really, above all, a visiting nurse is there to provide education. This is a person that's helpful on the path to recovery. They're there to teach how to manage medications, to use medical devices, to teach someone how to perform their own wound care. And the goal of home care is for recovery or better management of a chronic condition. It's a short-term solution. This is not someone that comes into your home every day for long periods of time or, for years on end. These usually happen in 30, 60, 90-day stints, or as we like to call them, episodes, where we have these episodes of care where the real progression is toward meeting your goals of getting back to your activities of daily living. The core idea of home health is to bring these professionals into your home to allow you to recover or manage your chronic illness without needing to be in a hospital, needing to be in a long-term care facility or a rehab facility. It's to help you manage that care at home and have your loved ones help you manage that care. Think of it more like doctor's appointments in your own home, rather than you having to go back to the doctor every single day for wound care. This is someone that can come to you for 45 minutes, an hour, work with you, and make sure that you have what you need, you don't have the complications, and you don't have to have all the stress and worry of getting to the doctor when you're feeling pretty crummy. VNA services, and let me just note this here, VNA services are often paid through Medicare, Medicaid, or other private insurances. There are sometimes copays depending on your insurance, but just like going to the doctor, these services are often covered by your insurance. There are sometimes limitations. The biggest limitation to home health care is that you have to be certified as homebound. It has to be very difficult for you to leave your house. So, for example, someone that has a hip replacement, it's really difficult for you to leave your house after a hip replacement for the first few weeks. And that would be a great time for home care to come in, have the nurse help manage wound care, have some PT and OT right in your home as you're recovering. And then when you're ready for outpatient, when you're ready to start leaving the house more regularly, that's when you would be transitioned to an outpatient, when you're seeing someone less frequently than you might need in home care. So let's talk a little bit more about physical therapy and occupational therapy. These are common services that happen in outpatient. I know that many people, including myself, have received some of these over the years. Physical therapy, these are folks that come into the home to build a program with you to restore strength, balance, or functional mobility. They might assess for fall risk, or teach you about fall recovery. If you do fall at home, how do you get back up? What should you do after a fall? When should you really take yourself to the ER or call 911 after you've had a fall? They can also help with gait training. if you have had that hip replacement, you might start out with a walker and then need to transition to a cane and get back to walking independently. They can help teach you how to use those devices appropriately and also make it safe in your home to use those devices because sometimes it's the first time you've ever had an assisted device, and that pathway between where your TV is and the kitchen counter, is too small for the walker. And making that safe throughout your house is a primary way that physical therapy can come in and help. Occupational therapy is focused on helping people maintain or regain the ability to perform everyday activities. So they are looking at doing home safety evaluations. Can you shower appropriately and safely? Can you get in and out of the tub? Do you need adaptive strategies to help you do the things that you want to do? And energy conservation. If you've been ill and been in the hospital for a long time, you might not have a lot of energy. What do you need to be able to do to shower yourself instead of having someone help you? How can you conserve energy for that? Both OT and PT do assessments, they're making plans, and again, they're teaching the patients and their family members on how to be successful with these programs. And one big difference between PT and OT is PT is focusing really on how the patient moves with strength and balance and gait, and OT is really focusing on what you do with that movement. Not just that you can walk, but that I want to be able to take my granddaughter on a walk. I want to be able to ride my bike again so that I can ride to the park, And because of those things, PT and OT collaborate really closely often to make sure that we're maximizing independence, making sure that we're getting back to where the patient's goals are. And do you have a question? Did I see a hand? Okay, sorry. That's right. I love questions. I'm on the lookout. Medical social workers, another key part of this team. Medical social workers help layer on the services to fully support patients. They're addressing social, emotional, practical factors that affect a patient's health and ability to manage at home. Essentially, they're sort of coming at the patient with a broad lens. While nursing or PT or OT may have really specific clinical focus, a social worker is going to take a step back and say, is this patient having trouble because they're worried about being able to pay for this service? Do we need to look into financial assistance? Have we thought about long-term care planning? Have we had talks about advanced directives? Have we had talks about what's hospice? How does that work when we get there? They are excellent at having really challenging conversations and are really, really important parts of the care team to make sure that we're caring for the whole patient and the whole family. And then our home health aides and our LNAs, who are such a key part of the care team. Home health aides are often in the home more frequently than nurses or PTs or OTs. They are a key communicator back to the team about, oh gosh, Mrs. Smith said that she fell last night. She looks okay. What should we do next? Or making sure that, that communication among the team is happening. And they're great at hands-on care. They're providing bathing, showering, they're assisting with dressing changes, maybe helping with a little bit of laundry to make sure that that the person is being taken care of well and that their quality of life is really there. Yes. Is
that something that's only the episode as well? Or
yes.
Okay.
It is all within the episode. We can't pick and choose one or more of these services. And all the VNA services come with a doctor's order. We have to have, as part of the referral process into this program, when you meet with your physician or being discharged from the hospital, the doctor who's making the referral will help guide what services they think you need, and we'll also do assessments to say, okay, the doctor said that you definitely need nursing and PT. I really think you should benefit from OT as well. Let's make sure that we're getting that doctor's order so that we can fully support your recovery.
So is there some type of services out there for long-term for folks that are still living on their own but need help with the bathing and that type of thing?
We don't have that at HCS. I know that there are other organizations that do that, though. They call it private duty often. Those are key terms to look for when you're looking at that. But we know that that's a need, and we know that there are other organizations that are doing that.
Thank you.
You're welcome. Did I see another question before I move on? All right. All right, so let's talk about hospice. This is another one of our clinical programs. Hospice is care that is focused entirely on keeping a very seriously ill person comfortable, peaceful, and surrounded by those that they love. Here, the goal is shifting from fighting disease to making whatever time remains valuable, pain-free, and meaningful. To qualify for hospice, two things must be true. First, a physician must certify that if your illness takes its natural course, you have 6 months or less of life. This can apply to any terminal illness. This can apply to, cancer, heart failure, dementia, and nobody can really give you an exact amount of time left. But by best clinical judgment, a doctor can help with that and help guide toward hospice at that time. The second thing, and just as importantly, the patient themselves must make the decision to stop pursuing any curative treatment and to pursue hospice and transition that care focus to comfort and quality of life. It's never imposed upon anyone. Hospice is not something that you have to have, but it is a choice and a decision made by a patient and their family when they're ready, on their own terms, in their own time. Yes?
You use the word doctor.
Yes.
Is it only a doctor, or is a nurse practitioner qualify, or some other provider, or does it have to be a MD?
Yeah, so you're a physician, so this might be a cardiologist. It's usually an MD or a DO who says this is you're now eligible. Mm-hmm. And what will happen is they'll send that referral in, and we have the hospice certified, palliative certified physician on our team who is that second source of saying, yes, this person qualifies. So your nurse practitioner, because we know a lot of times your primary care physician is a nurse practitioner,
Mm-hmm.
can make that initial referral, but it will have to be certified by our medical director as well.
And going back to the VNA services as well, that can be done by an APRN. So those services can be either by an MD, DO, or APRN. But hospice, those referrals can come from any of those places, but then, as Tali said, will need to be certified by our medical director. Yes?
You emphasized that it would be the patient's decision or agreement, and then you added the family as well. When the patient or client doesn't seem cognitively, has had significant changes in their mental status in
Yeah.
that regard,
Mm-hmm.
is there additional process to determine whether they can make the choice? If they resist and the family sees something else, is there some type of further assessment that is done to?
I think this is one of the reasons why it's so important to do advanced planning and get advanced directives in place, because when cognitive changes happen, it's important to have a healthcare proxy in place. Next, if someone is truly unable to make their own decisions and are certified from a doctor saying they can't make their own decisions, the next of kin, whether there's anything in place or not, next of kin can make those decisions. If you want someone else to be making those decisions. That's why it's so important to put advance directives in place. And we have other seminars that we do about advance directives. We have a great project going with one of the family medicine residents at Cheshire Medical Center where we're working on spreading the news about advance directives. Anybody can have them. Everybody should have them. And so we have a lot more information about that we can share in sort of a different format. But does that answer your question, or do you have further questions about that?
Honestly, I was leaning more toward experiences that I've been involved with.
Sure.
Where the patient plan is, in certain situations, is clearly unable to, and some of the people involved were lay people and others were professionals, but not directly overseeing the care for that person. And that client or that person, patient, didn't seem to be making safe choices on a daily basis.
Yeah. Well, it really, if that person has not designated a healthcare proxy, they would still have the opportunity to choose or not choose.
To decline.
Yes. And we've seen that
To be on
happen.
their own.
Yes, and we've seen that happen. And you know, those are get to be really tough situations, and that's when having social workers involved, and we have some fabulous care transition specialists that work with HCS as well that can sit and listen to the concerns and hear really what the big concerns are. There's a lot more available in hospice care than in visiting nurse services, and I know that when my own mother was in that situation and she couldn't choose for herself and it was up to me, I was counting down the days. I kept asking her doctor. I was like, "Is it time? Can we get our hospice benefit yet? Is it time? Is it time?" And not that I was wishing ill on my own mother at all, but I knew how much more care she would get and what better quality of life she would have with the full support of a hospice team. And she was on hospice for much longer than 6 months. So,
Can I kind of?
yeah,
go on with that?
sure.
Just the other aspect of my experience is that, so they agreed to it initially, but then they.
You can revoke at any time.
Right.
Anytime.
They resist the visits, okay.
You can revoke at any time, and if some miracle cure comes out and you choose to seek curative care, you may absolutely revoke at any time. And hospice doesn't mean that you can't seek treatment for other things too. For example, if you get a urinary tract infection, it's not that we're not going to treat that. It's that we're not treating the metastatic brain cancer. You know, we're not treating the big elephant in the room, but we are making sure that you're comfortable and that your loved one is comfortable and as pain-free and as distress-free as possible. You're so welcome. Sorry,
No,
go
sorry,
ahead.
I was just gonna say in addition to that too, if they graduate off, it's not held against the patient
Yeah.
either. You can always come back on and
Sure.
there's no like ill will or stopping of Medicare providing that service. So you can come off and on as
Yeah.
need be certified by the physician.
Absolutely. We have certainly graduated some people when they've come on hospice and then they've gotten well, you know, they've done really, really well. And then, you know, 6, 10 months, a year later, sometimes they'll come back. And sometimes they'll have the exact same care team that they had before. So it's like riding a bike. But that is, you can see here that we have many of the same, let me see if I can get my clicker. Yeah. So we have many of the same services available as, and we call them disciplines services available as in the visiting nurses. So we have our registered nurse case managers that are doing a lot of the management of care. We have home health aides, we have PT and OT and medical social workers. but we have a much broader suite of things available to continue to support the patients and their families. Tally brought up earlier our hospice and palliative board certified physician as a medical director. We always have a medical director on call. Ours is Dr. Lisa Leinau, and we have a backup for her, Dr. Andy Kunkemuller, who works with us. So we always have a medical director ready and available to help with things that come up. We also have a couple of advanced practice registered nurses with us to help, again, with that higher level of care. More complicated situations come up with hospice, and so we want to make sure that we're supporting our staff with the right level of clinical care to best support our patients and clients. And then the beautiful part about hospice is we have a large suite of things to support the social and emotional part of being at the end of life, and for families as well. We have bereavement counseling. Part of the hospice benefit is 13 months of bereavement after a loved one passes away. We have spiritual care coordinators. We have massage therapists and touch intervention. We have music practitioners. And boy, oh boy, we have a fabulous small army of volunteers that can do some of that more respite care. They can come and sit with your loved one while you go to the grocery store, just take a hot shower, take a break, get away for a little bit. And these volunteers work with the family the whole time that they're on our service, and they are fabulous. We are always welcoming people into our small volunteer group, and we run multiple trainings throughout the year. We're expecting the next one to start in May or June. We don't have the dates yet. But if you're interested, or if you know anyone that might make an excellent hospice volunteer, we'd be happy to talk with you or talk with them afterwards. And I can't leave hospice behind without talking about our annual butterfly release. We have this event in June each year. This year, the dates are the 18th, 19th, and 20th of June. And the first day is always at the Cathedral of the Pines in Ringe. And then the Friday and Saturday, we host at the HCS Keene office in Butterfly Park. It is a fabulous, beautiful time to reconnect families with caregivers, to remember those that we have lost, and it is a magical, really a poignant day, and it is some of my favorite working days every year. So if you haven't joined us before, we can make sure that you get information about it, and it is a lovely, lovely time. We also have bereavement and caregiver support groups. I mentioned 13 months of bereavement. This starts with a grief support series. In the first six weeks or so after you're recently bereaved, we have this support series where you meet once a week to talk about what you're going through. And we have people in cohorts who are about at their same stage of grief. So this is a fabulous thing that we have. We have caregiver support groups as well for those who are taking care of people long-term. We have two. Right now they're meeting at the Keene office. We have one on Wednesdays from 1 to 2 p.m. and Thursdays at 11 to 12. And both of those groups, you have to register the first time just so we have your information, but then you can come to those groups, and they're run by a nurse and a social worker at HCS. So not only do you get great facilitation from an HCS staff member, you are getting the benefit of their clinical expertise and someone that's worked with a lot of people going through difficult caregiving situations for a really long time that can offer sound clinical judgment and, can maybe pull you aside and say, I've heard the last few weeks you're going through this challenge. Maybe it's time to go back to your PCP, your care provider, and ask for XYZ to help guide the path of caregiving. All right, let's talk about a different program. We'll move away from hospice. And we'll touch on Healthy Starts at HCS. So Healthy Starts is a team of social workers and home visitors that are building a village of supports to help our clients thrive. I like to lump this in with the other clinical programs because there is such a rich partnership between the Healthy Starts and the VNA, our visiting nurses, to provide prenatal education, postpartum visits, lactation consulting and education, health education, and support for children with complex medical needs. If there's been a congenital birth defect, or if there's a childhood cancer diagnosis, we always make 2 referrals at once. Whenever a referral comes into the VNA to support that child, we make a partner referral to Healthy Starts to make sure that we're really wrapping our arms around the whole family to do everything we can to support that family going through such a challenging time. Our Healthy Starts family support workers can help find medical coverage. They can help with the New Hampshire Medicaid application. They do development screenings for children. They can help apply for WIC or SNAP or other nutrition services. They can help locate housing assistance. We have many people come to us when they're either on the brink of or have just been unhoused. They can help connect to medical homes. And again, education. All of our staff are constantly trying to provide education. They can provide parenting education. They can do child development screenings. And they're also so knowledgeable, not only about the resources at HCS, but about all the resources in our communities. And they're excellent connectors. They know what programs and services are available to help really connect the families with what they need to help them be stable and to thrive. Healthy Starts also has a really fabulous partnership with the New Hampshire Children's Trust. Throughout New Hampshire, there's a growing number of grandparents, family members, other close family friends who are raising children whose biological parents cannot care for them. We call them kinship caregivers, and they're providing these safe and nurturing environments for these children. And you can imagine that maybe if you haven't parented in 30 years, parenting looks a lot different these days, which I can vouch for as someone with a 10-year-old. Parenting looks a lot different these days than it did 30 years ago. And being in this world of phones and AI and social media, you might need some resources to help you. And that's what kinship caregiving does. Also, it can provide concrete supports too. If you're a single person who suddenly has your sister's 3 kids and you've never had children before, you need a lot of stuff to have 3 kids. We can provide concrete supports to get bunk beds, to get food assistance and other things to make sure that we're setting those families up for success. All right, we're going to move on from our clinical programs into some of our community programs. So, as I said before, many of the community programs at HCS are geocentric around the places that fund them. For us, that tends to be Cheshire County and sometimes the city of Keene. So I'm going to be really clear about where these services are available, just so that I don't misconstrue something and you think that it's available here in Peterborough when it's really only available in the city of Keene. So first are the foot clinics. This is absolutely available right here, right over there. So a foot care nurse will trim toenails, teach about good foot care, massage feet with lotion, and generally make sure that your feet are doing great, because the feet are gateways to independence. If your feet are doing well, that's a great sign. Our foot clinic nurses also act as community wellness nurses. They don't just sit there and take care of your feet. They're asking you, how's your health been? How are things going? Have you had any falls lately? How are you eating? How are things going? Have you had any new diagnoses that I should know about? To really, again, listen for things that might be risk factors or things that they could help you with or connect you with other services at HCS and elsewhere. I hope you hear the word connectors a lot, because that's really what I think of when I'm thinking of our clinicians and when I'm thinking of our staff. Even if we can't provide the service at HCS, we want to make sure that you get to the people that can. So our foot clinic nurses are often acting as these community wellness nurses. Yes?
Is this a referral?
It does not need a referral in general. However, if you have diabetes or are on a blood thinner, we do ask for a doctor's referral, so we have doctor's orders if something needs to happen. Just because those are situations where feet are more sensitive and tend to have more issues, those are the only situations where we have to have a doctor's referral. But in general, if you don't have those, in the most part, you can just call our foot clinic and we'll get you an appointment and you can come visit us. Friendly meals. So we have multiple nutrition services at HCS, one of which is Meals on Wheels, which is only available in Cheshire County. But Friendly Meals, we offer Friendly Meals in Jaffrey every Wednesday at 11:30 a.m. And Friendly Meals is a program where if you are over the age of 60, you can come and have a meal with us. And it's a great experience. You can meet some people, you can talk to some people. It is free. You do not have to pay anything to come. If you would like to make a donation, we would appreciate it. But you are not required to. We won't kick you out. We would just be happy to have you there. We also offer this at the Keene Senior Center. This is one of the ways that we partner with them, and we offer meals there 5 days a week, so every weekday. I love the United Church of Jaffrey group, though. They have a really wonderful group that comes there, and I love going and having lunch with them sometimes to hear what they're up to. And it's a great way to stay connected. It's a great way to get out of the house every once in a while, and it's a great way to meet some new people in your community. So, yeah. Yes?
Do you have to be a resident of that town, or can
You do not. Just show up. Homemakers and home support. Now, this is offered only in Cheshire County, but this is a program that helps older adults and individuals with disabilities, and generally folks that are pretty low on the income spectrum, to maintain cleanliness in their homes. So when non-medical activities of daily living become really difficult, this is a place where our folks can come in and help pick up groceries, go pick up prescriptions, do some laundry, change the bedding. You know, this is not hands-on care like an LNA, but this is something that is more long-term. So like you were asking before, these folks can't help with showering, but they could help doing some dishes, doing some meal prep, taking out the garbage. And this is something that helps individuals remain as independent as possible. And I'm also going to give a nod to the other Cheshire County services that we have too. I mentioned Meals on Wheels. This is for homebound seniors and individuals with disabilities. We make over 400 deliveries a day and are on track to provide 92,000 meals in Cheshire County this year. Our Meals on Wheels population are people that are really struggling to get out of the house or don't have other social networks. Over 40% of our Meals on Wheels clients say that their driver is the only person that they see. Hard stop. And then even more tell us that it's the only person that they regularly see, that they're seeing other people, they have other social networks, but the driver is really one of the very few people that checks in on them on a regular basis. And we have, I think about 70% of folks tell us that their income is low enough that they're not getting nutrition from other sources, that we're providing the primary source of nutrition, and that there are some folks that are saving the meals that we get. They eat part of it and they eat other parts of it later in the day so that they can have 2 meals. But ultimately, this is a way that we can also help people be safe at home. It is a daily safety check. It is not just nutrition. 92% of our clients say that they feel safer at home knowing that someone is going to check on them every day. And even if they don't get a meal that day, they get a phone call. For example, on one of the days that we had a big blizzard, our drivers take some time in the morning to still call all their clients, check in, see how they're doing, make sure they're okay, make sure they have something that day. We also have transportation services at HCS, and this one is really, really bound to the City of Keene. Most of our funding comes from the City of Keene and from Department of Transportation for that. So we have a City Express bus in the City of Keene and a Friendly bus that operates in the City of Keene. Friendly bus is more door-to-door, while City Express bus is public transit. It follows a route. We do have medical transportation up to Dartmouth-Hitchcock Medical Center and the VA. So once a week, we have transportation that goes, it's a shared ride transportation. If you can make it to the Keene office, we're happy to take you all the way up to Dartmouth-Hitchcock, because we know our fabulous community hospitals like Monadnock Community Hospital and Cheshire Medical Center, they do really fabulous work, but we know there are certain specialties that exist at Dartmouth that really don't exist anywhere closer than Boston to us as well. So this is an opportunity to be able to travel up to those services. It's a very low cost. For veterans, it's free. And for others, it is $20. You can bring a caregiver with you for free. If you're having a medical procedure, something that you have anesthesia, we require you to bring someone with you. And again, that person is free. So we're happy to have those transportation, but I know that they don't come all the way out here. Yes?
I got to ask a question about
Sure.
Meals on Wheels. Where do you get the meals?
When do you get the meals?
Or where?
Where? Oh, we have a company that we work with out of, I think they're out of Rutland, Vermont. And they actually, one of the big things that they do is provide meals for Meals on Wheels. So they package it. There's really specific nutrition requirements for Meals on Wheels to make sure that we're not just sending you out like a lean cuisine and, that we're providing nutritionally dense food that is not too high sodium, not too high fat. So the company that we work with is called Trio Community Meals.
That's a lot of deliveries in a day.
It is. It is a lot of deliveries. We have a small army of delivery drivers and also a small army of volunteers. We have multiple routes throughout Cheshire County, and 3 of those routes are completely staffed by volunteers. So our Westmoreland, our Jaffrey, and our Ringe routes are all completely staffed by volunteers. And we have volunteer managers that help organize those routes for us. And we could not do everything that we're doing without the support of our volunteers. And also supportive donations. It costs us about $13.50 for each meal that goes out the door. We only get reimbursed about $8.68 per meal. So that's a $5 deficit. For every meal that goes out the door, HCS is losing $5. And those are things that we are grateful for philanthropy, we're grateful for grants, we're grateful for organizations that donate to make sure that we can still get those meals out the door. Yes?
You were talking about once a week the bus goes to Dartmouth.
Yes.
Is that a particular day?
Wednesday.
It's always Wednesday.
It is always Wednesday, so that you can plan your appointments in advance and know that it will always be Wednesday. Yes?
I noticed that Meals on Wheels are not everywhere.
That's correct.
So
Meals on Wheels is,
it's just the Keene area.
our Meals on Wheels is only for Cheshire County. So we serve most towns in Cheshire County, and if it's not a town that we already serve, we do our best to get you on one of our routes or get a volunteer to bring things to further towns in Cheshire County. There are other organizations that do Sullivan and Hillsborough counties. There is a Hillsborough County Meals on Wheels and a Sullivan County Meals on Wheels. They're not actually called that. I can't remember what their name is. But I know that there are other fantastic organizations that we work with collaboratively. If we get a referral from somebody in Peterborough who needs Meals on Wheels, we make sure it gets to the right place.
And you have to be a certain income level or below a certain income level?
So the way that Meals on Wheels is paid for is through title programs through the state. It is helpful if you are over the age of 60. That reduces a lot of the other barriers for it. But it's also, you have to attest that you make less than, I think, $1,600 a month. So generally, the folks that are receiving Meals on Wheels are folks that are not making a lot of money or not bringing in a lot of income. We do have some programs that are not income dependent, but they ask us to first look at those that really can't.
Yeah, because sometimes it's not the money, it's you don't have the time or the ability.
That's true. And so we do have, they call them units that we can allocate, and we certainly do have units that we can allocate to make sure that we are serving that population too. Generally, one of the things I'm most proud of at HCS, if someone comes to us for help, we don't immediately say no. You know, we do our best to really help make sure that they're getting the meal, the safety check, or to find out a way that we can support them, even if it's not a service that HCS provides. Yeah.
While we're talking about money, I was waiting because I thought maybe we were going to cover it, but what about hospice? When I was a volunteer and when I had family members use it, it didn't cost us anything. But I've heard from some other people, and I didn't know if it was true or not, that now it does cost money.
Nope. Hospice is a Medicare benefit. It's all paid for by Medicare.
Still is. Then.
Still is. Still is. And other private insurances too. If you have other private insurances, most often it is fully covered by private insurances. Well, I've told you a lot about programs and HCS services, but I'm going to tell you one more thing. And if you only take away one thing from this presentation today, please let it be this. I know I've told you a lot about our programs and services, but there's a lot to learn. And there's so much that I didn't cover about what we do. HCS has what we call Walk-in Wednesdays. Every single Wednesday from 1 to 3 p.m., both at the Keene office and in our Peterborough office. This is a time that we have a staff member available to hear from you, to hear about your specific situation, to hear about your questions, so that you can come in and tell us about, oh, my mom is moving in and I still have to work, but I need someone to check on her every day, or how can I get her to doctor's appointments, or, you know, can you tell me, like, I need to get her enrolled in Medicaid so that she can move into an assisted living facility. You know, this is the time to come tell us your story and have us help figure out what we can do for you. You don't have to know all of the things. You don't have to know all of the programs. You just have to know that we're here and to know that we want to be helpful to you and to be connectors, to connect you to the services that we have and the services that other organizations have too. So we encourage you to come visit us at Walk-in Wednesdays from 1 to 3 p.m. You might talk to Tally. You might talk to me. You might talk to Nancy Onosorge, who's here in Peterborough. And we are happy to listen to your specific situations. And there's no pressure. We're not going to have you sign up for anything. We won't even take your name if you don't want us to. But we will be a listening ear. We will tell you what we know about the services. We will tell you what we know about advanced directives and planning and how you can better plan and what we know about the services that exist around us. We can also do this virtually. If you're tech savvy and travel is a problem, we are happy to meet you virtually. And of course, we always still take the walk-in Tuesdays and the phone call Friday afternoons. And we absolutely will do our best to answer any question if you call us at any time. But this is a time that we have somebody ready and waiting to talk to you. So that's what I have for you today. Thank you so much. I'm happy to answer any questions. I know we have a few more minutes. I didn't talk all your ears off. I see one in the back.
Did I hear or understand correctly that your services are not available to people with Alzheimer's?
Our services are absolutely available to people with Alzheimer's. Yes. Especially our hospice services, our VNA services, if there's been an illness. And you know, with VNA, we're trying to get back to regular activities of daily living. So maybe if there's an illness or a fall, you know, we can help with the recovery from that. We know we can't heal the Alzheimer's, but we know we can get someone back to a rough level of where they were before. So all of those services are available to anyone with any form of dementia. Yes.
For people with portacasts,
Mhm.
if they're receiving chemotherapy.
Yep.
If it's a challenge for them to get into the infusion center for just a maintenance flush,
Mhm.
do you have trained nurses in ports?
We do have nurses that are certified in immunotherapy and in infusion care. Generally, they're on services with us for other things. We don't generally do sort of one-off appointments for flushes and things like that, but we have definitely worked with folks that needed regular chemotherapy infusions that we are coming to their house to do that.
Wow, okay, thank you.
Yes.
Thank you very much for the overview. That's really helpful. And I've had some great experiences over in Hillsborough County. I grew up in Hollis, and both my parents used hospice, and my older brother, and now I'm 84. And I used to be a volunteer fireman and drove an ambulance for 35 years. And then I had a heart attack in March 2nd, 2018, and it's really weird to be in the ambulance,
Yeah.
in the back.
Yeah.
And so I wrote a book about, back from the edge. And it's a lot of humor and self-directed. I'll give you a joke. I went to my primary doctor, after my heart attack, and I worked in the hospital over in Nashua. And I said to the nurse, "Tell me a good heart attack joke." And she said, "Don't have a heart attack while playing charades." And then another one about memory loss. A couple of weeks ago, I went out for lunch with a bunch of my peers, and I'm really worried that one of my very best friends is losing in short-term memory, but I can't remember which one. So the idea is to be able to laugh at it. And,
Yeah.
I wrote this book about who helps the helpers, and it's all dark humor. It's really
Yeah.
not for the ladies, but you have to laugh. And I specialize in addictive problems and grief and loss. And if you don't laugh, for example, if you went to some open AA meetings and you listen to the pain and suffering that the people are telling you, drunkalogs, the old timers are laughing in the back of the room, not at the person. They're laughing at, I've been there and done that.
Yeah.
And
Yeah.
so it's very healthy and humbling to be able to laugh.
And that's something that I love about our organization. We have a really wonderful culture with our staff, and we do laugh a lot. We really like having a good time. When we recognize our staff, we like to get together, and there's always so much laughter in the rooms. And yes, there certainly is dark humor sometimes when you're dealing with many of the things that our care providers deal with on a regular basis. But you know what? They are fantastic people that are really showing up to do the good work with all the people. Yes, ma'am.
I have a hypothetical question. If all of a sudden I became ill and needed, I'm of 11, and I needed 24-hour care, and my daughter couldn't come every day, how long would it take to get that service? I didn't want to leave my home.
If you don't want to leave your home, right now, that's something that you would need to privately pay for. That's not a service that HCS can provide. Like I said, like our nurses are more, and even our hospice providers, it's more like a visiting doctor, where you have a visiting doctor's appointment that you don't have to leave your house for. It is very rarely like long blocks of time that someone would spend in the house with you. Those services certainly are available through private pay, but one of the things that we're assessing for when our nurses are first going into the home, whether it's for VNA or for hospice, is this person safe at home? Are they safe here alone? Are they safe here with their caregiver? Because sometimes caregivers are just as frail as the person that they're caring for. And in times when that person is not safe, we have absolutely sent folks right back to the hospital and said, "I'm so sorry, you're not safe at home. We can't safely care for you here. Let's find a different solution." Often in those situations, if you don't want to leave your home, that's when it's really important to have advance directives so that your wishes are known especially if you can't speak for yourself in those times. And sometimes we do everything we can. We do everything we can to keep people as independent as possible and to have their wishes carried out for their own personal beliefs and choices. It's baked into our mission. We want to help with that at all costs. But when safety is really an issue, we have to make sure that first and foremost that person is safe and getting the quality care that they need. And sometimes that means that we recommend that they go to a rehab facility or a skilled nursing facility because we can't safely care for them in their homes. Yeah.
So who would come in and determine that? Just one of your visiting nurses?
Yeah, generally our nurses would come in and they would make a recommendation at that point. They would either say, yes, you're appropriate for home health services, everything looks good, and they admit you to our service. But if it's not if they're feeling that it's not an appropriate situation, they always bubble it up to our managers and our medical directors to help with that key decision making, because that's not a decision that one person can make lightly. You know, they want to make sure that they're bringing the care team involved in that as well.
It doesn't put all the blame on the caregiver.
Yes. Yes.
What about respite?
Respite is available for hospice services. That's not part of VNA services, but there are respite services available for hospice. And in fact, Monadnock Community Hospital is a fabulous partner with us in our hospice for respite services. We often do respite here or at Jaffrey Rehab, where, you know, if the caregivers are really burnt out, or symptoms are totally uncontrolled. You know, if someone is at a part of their end-of-life process that they're in a lot of pain or they're having a lot of nausea, sometimes the best thing to do is to have a few days of 24-hour care at a hospital or at a skilled nursing facility where we really can have a nurse there all the time to make sure that we're getting those symptoms under control, that you are feeling the best that you can before we bring you back home.
Do you have volunteers that come in for like 2 or 3 hours?
Yep. Volunteers absolutely do that as part of the hospice program. Yeah. Yeah.
I think when I saw the picture of your building, I think you host death cafes.
We absolutely do.
And so, you know, just a wonderful open forum, not a support group or anything.
Nope.
But that's just a nice service that you do.
We do. We host death cafes quarterly, and they are we flip-flop back between Keene and Peterborough. So sometimes we host them here, sometimes we're hosting them at our Keene office. So you get twice a year in either location to visit us. Those are run by Jessica Johansson, who is another great collaborator with our organization. She's a death doula, and this could send us down a whole other track. We could talk about this for like a whole other hour, but I promise to spare you. But that is a great way to talk about death. Bring your questions, talk about experiences that you've had, and she really fosters a safe environment to be able to talk about anything you really want to. And each conversation, each death cafe is so different. There are no two that are alike because they're different people talking about different things at different stages of their questions or curiosity or fear or grief. Yeah.
So again, regarding Alzheimer's, I know
Sure.
you said visiting nurses assistance is available, but in terms of like a companion to give my dad a break a little bit, is there any organization that does that? Is it just strictly like private pay, or where would we look for assistance for that?
There are organizations that do that, and you'll find that they're all private pay.
Okay.
There are very few of those that have any kind of reimbursement through insurance. Often, if they are, insurance would be like long-term care insurance, and they'd be looking for placement in a facility at that point.
Okay. And where would we find lists of potential?
You can come to a walk-in Wednesday.
Okay, that's what I was thinking.
Come to a walk-in Wednesday. We can talk more about it. We can talk more about where you live, what organizations are around you, what other support might be available.
Okay, yeah, because we're just looking for support. She does not want to go anywhere. And
I
I
know.
can only do so much while I'm working during the week, so I want my dad to have some support.
Yeah.
Okay, thank you.
You're so welcome. Thank you all. I'm happy to stay and answer some more questions, but I know we've run over a little bit. So I'll be up here if you want to come and chat. But thank you all so much for attending today. It's been a pleasure chatting with you all today. Thank you so much.